My topic for discussion today I have slightly modified because I see that there are two topics which will be speaking of GI bleed, the medical part and the surgical part. So what I have done basically is to restrict myself to GERD management and its future as far as the AI is concerned. We are all aware what AI is doing to all of us, and probably no one sitting here will be able to continue without using AI in his or her practice. So now coming to the topic, GERD, by definition we all know that GERD is the condition which is the reflux of gastric contents into the esophagus and beyond. So it is just not esophagus. So we get symptoms in other areas as well, the oral cavity, the larynx, the respiratory system, so on and so forth. But that is the theoretical definition. The objective definition is to really prove the presence of the characteristic mucosal injury, maybe by doing certain invasive investigations. What is the prevalence? If we talk of the Western prevalence, it is somewhere around 20%. But if we talk of prevalence in India, it is, depending upon various studies, somewhere around 7.6 to 30%. What are the phenotypic presentations of GERD? It can be any RD where we don't see the reflux. So it is non-erosive, no erosion there. So non-erosive reflux disease, that is NERD, erosive esophagitis, and the Barrett's esophagus. There are various trigger factors to this particular condition, which can be physiological, transient relaxation of the lower esophageal sphincter leading to decrease in tone. It can be drugs, there can be contributory, there can be lifestyle things like obesity, smoking, diet, lack of sleep, other factors like pregnancy, stress, and other factors leading to increase in intra-abdominal pressure. The common symptoms are gastrointestinal, but there can be extra-intestinal symptoms as well, to which I'll allude later on. What is more important to remember, that there are certain red flags to it, like chest pain, GI bleeding, choking sensation, painful deglutition known as rhinophagia, dysphagia, and they have to be always kept in mind once we are diagnosing a patient to be having GERD. So how do we classify? Classify it into grade A, B, C, and D. This is the Los Angeles classification, where if the tear is less than 5 millimeters, it is grade A. If it is more than 5 millimeters, but not involving other mucosal folds, it is grade B. If it is involving more than one mucosal folds, but less than 75% of the circumference, it is grade C. And if it is more than 75% circumference of the LES, then it is grade D. So this is how we classify on endoscopy the grading of GERD. Now GERD doesn't always have the GI symptoms. It also has extra esophageal symptoms. They can be ENT associated, laryngitis, sinusitis, pharyngitis, otitis media, or dental erosions. Respiratory associations with asthma, chronic obstructive pulmonary disease, pulmonary fibrosis, cystic fibrosis, bronchiectasis, bronchiolitis, and OSA, about which there is another lecture to follow. So there are strong associations with important disorders, what we see in our day-to-day clinical practice, that is bronchial asthma, COPD, hypertension, and diabetes in significant proportions. If we talk of the involvement and connection with the respiratory diseases, then it basically, if we talk of how it happens, then we can see that there are abnormal lung mechanisms which can lead to GERD. There can be altered lung volumes, reduced lung compliance, or maybe the diaphragmatic displacement, all basically affecting the lower esophageal tone, and that will propagate more of reflux into the esophagus. It can be coupled with the proximal reflux as well because of the tone which is there in the upper esophageal sphincter that can go down, and finally contributing to micro aspirations into the respiratory tract, contributing to the cough, and the patient can come to you with some irritation in the throat which is happening for a pretty long time and a chronic cough. If we talk of other mechanisms, Then there can be like the physiological esophageal exposure to reflux. There can be central neuronal sensitization, and these all can also contribute towards the cough, and the patient can come to you with chronic cough and not maybe having the GI symptoms. If we talk of association with other important conditions like diabetes, hypertension and obesity, so diabetes contributes in more than one way. It can be directly through hyperglycemia or through the complications of diabetes involving the neuronal pathway, the neuropathy, or maybe the obesity per se, which itself is connected with diabetes in significant proportions. All these factors, they culminate to GERD. So there is a very strong link between GERD and diabetes. If we talk of GERD and hypertension, the association is because of the common risk factors. These risk factors are age, obesity, male gender, smoking, alcohol consumption, and education level. If we talk of GERD and obesity, then there are multiple factors where in obese patient it contributes to GERD. It can be increased sensitivity to the acid in esophagus, high hernia, increased intra-abdominal pressure, vagal abnormalities, increased gastroesophageal pressure gradient, lack of basal gastric suppression, and higher maximal gastric acid response to IV pentagastric. So these are ways in which GERD is connected to various important other things, and we at times tend to forget GERD in the background of those major diseases. And that's why this is one condition where we basically overdiagnose rather than underdiagnose in our clinical practice. The moment the person comes with some sort of GI symptoms, upper GI symptoms, we tend to put this diagnosis in place and start treating them with PPI. So this is where we have to be cautious, and I'll let you know why. Why this happens? The reason behind is that to prove GERD we need invasive methods, and these invasive methods can be upper GI endoscopy, pH monitoring, ambulatory catheter-based, or it can be a FBS test, esophageal manometry. Now this is one question: how many times other than upper GI endoscopy we all really get these investigations done to prove GERD in place? So this is the bigger question, and that's why non-invasive methods such as questionnaire-based screening is in place, where we can simply hand over a questionnaire to the person. He himself can tick the questions placed in that question paper. We can simply make a total and put the probable diagnosis of GERD. So non-invasive methods such as questionnaires, they are accepted form, and there are multiple questionnaires which are available. One of the most common one is the FSST, which is the frequency scale for the symptoms of gastroesophageal reflux disease. More than 8 here on 12 questions which are asked on a score of 0 to 4 put the diagnosis of probability of GERD. Now this is an accepted thing, very easy. And it also has a capability of differentiating two modalities here. And one is the gastric dysmotility symptoms and the reflux symptoms as well. The darker ones, the black ones, they basically are the dysmotility symptoms, and the grey ones are the reflux symptoms. So this has got this extra sort of capability in identifying. Though there are various other questionnaires which are available, and you can see that the sensitivity and specificity of others may be a bit high, but still this FFSG is simpler because it is a self-administered questionnaire. It is a considerably simpler for patient. It is useful for objectively evaluating the therapeutic response. It may allow objective assessment of the therapeutic effect of various PPIs and evaluating the supraesophageal manifestations of GERD. So there are advantages to this FSSG. A very simply hand over this questionnaire. It will take maybe 2 or 3 minutes, and you get to know the probability of GERD in this individual. Now coming to the guidelines, which are our own guidelines published in JAPI just last year. So I thought that I will bring this also in the consideration, that what is the consensus here. The consensus, it goes into various sections. The first section speaks of the prevalent symptoms and common comorbidities. wherein whatsoever we have talked, besides that, it also talks of certain anti-diabetic drugs, certain anti-platelet drugs, and also anti-hypertensive drugs, which are to be considered as association or maybe the precipitating factor for GERD. Then the extraesophageal symptoms we have already talked about, they have to be remembered all the time whenever we are talking of GERD. The prevalence which is put by this association or this publication, as far as GERD symptoms in patients with respiratory disease is concerned, is somewhere around 50 to 30%. And if we talk of prevalence of GERD in diabetes, it is somewhere around 50%. So we have to be thinking about it whenever we see these important conditions. Now coming to the recommendations on the diagnosis. The diagnosis is basically starting from the medical history and then the non-invasive method which I have already communicated, and then we can straight away put the patient on PPI. Give a challenge of 4 to 6 weeks. If the person is improving, fine, fair enough. If suppose the patient is not improving, then we have to proceed forwards. And here comes the role of artificial intelligence. Because if suppose we are trying to go in for invasive methods, accepting for upper GI, which is well accepted by all of us, it is readily available, not very costly, and probably helps us in making the diagnosis perfect in most of the cases. But if suppose in situations where the endoscopic findings are also negative, the person continues to have symptoms despite challenge of PPI, what will you do? That is the question. And second, in situations where there is GI bleed, where the person is having, it's more than 40 years, a family history of carcinoma, dysplasia, anemia, and weight loss, or where the patient is having hiatus hernia, interstitial lung disease, reflux monitoring is recommended. In these sort of situations, we need to go further on to tests which are difficult to perform, not readily available, costly, and maybe probably most of the times research oriented. So here is where artificial intelligence is playing its role very importantly in this area of GERD. If we talk of AI, basically it works in 3 layers. The first layer is basically the computer algorithms. Second layer is the machine learning. And the third is the very important but very dangerous as well, and that is the deep learning, where automatically there are artificial neural networks which are developed within the software. There the software will try to analyze the data on its own and it will start commanding on its own. So deep learning is something which is very important for AI, but then this is very dangerous as well. And if we talk of the comparison between machine learning and the deep learning, there are subtle differences there. If we talk of definition, then the learning, the characteristics of data and finding the rules of its operation from the data is what is machine learning. But if we talk of deep learning, it is using multiple layers of non-linear methods to learn the data and then application. Data clustering, finding the abnormal value from the data, is something what is very easily done by machine learning. If we talk of deep learning, then it uses multiple things, multiple layers. And these are image recognition, image style transfer, language translation, speech recognition. In multiple ways the data is analyzed and then automated sort of commands like a human brain does is something which comes out of the deep learning. Advantages for machine learning, need smaller data, simpler to perform. But then, if we talk of the deep learning, it is widely applicable, it is going to be future, but then it is to solve complex problems which probably even human brain is not capable of doing it, but there are disadvantages. The machine learning needs lesser data in a simple modular form, but if we talk of deep learning, you need a very large database, multiple sort of analytics, multiple layers of, and multiple ways of analyzing those data. But the important part is that all this has to be validated. We cannot accept whatever the machine is telling us to do as far as the AI is concerned. Now coming back to AI, to GERD in the background of AI. What will AI be doing as far as the GERD is concerned? So in GERD, there are aspects which are not commonly addressed to by clinical testing. They are acid exposure time, what percentage of 24 hours time the esophagus is exposed to acid, the number of reflux episodes and the reflux symptom association happening throughout 24 hours. Then coming to the baseline impedance, we know that the refluxing acid will lead to dilated intracellular spaces, changing the conductivity of the cells and the impedance of the cell. And this has to be studied in multiple ways. And then coming to the post-reflux swallow-induced peristaltic wave. The moment there is a reflux of acid into the esophagus, the body will try to neutralize it by putting in some alkali from the throat or the upper esophagus into that area to neutralize that acid. So that keeps on happening spontaneously and automatically. But how to record it? This is something which can be easily done by the AI. So the first thing is the acid exposure time, that where AI is certainly not studied, not capable of doing good enough. But in other areas like number of reflux episodes, the cutoff values I have already labeled. 40 episodes is something which is physiological, more than 80 is which is taken as pathologic. Or if we talk of the mean nocturnal baseline impedance, the values are written there. And if we talk of the post-reflux swallow-induced peristaltic wave, more than 60%, 61% is once again pathological. And the sensitivity and the accuracy using AI is extremely good, to the tune of somewhere around 87 to 88%. So now let us see what artificial intelligence can be doing in these areas of GERD. So artificial intelligence for measuring number of reflux episodes. Now this was the first published study by Wingate, and it gives an accuracy of nearly 88.5%, which is great. If we talk of another more recent study, which is utilizing nearly 1,900 episodes in 106 patients, and here the patients, they were having negative endoscopy, and once again you can see that 87% is what AI is capable of picking up and putting the diagnosis of GERD in place. So now coming to another area, that is artificial intelligence for measuring the baseline impedance. So now this impedance phenomena can be nicely picked up by the artificial intelligence, and once again it is shown to be beneficial, it is shown to be superior. If we talk of PSPW, that is post-reflux swallow-induced peristaltic wave, once again, if we are comparing it with the best of the endoscopists here, once again the results show the potential of PSPW to be accurately and efficiently identified by artificial intelligence. So now that puts where today we are using artificial intelligence and where it is capable of giving us an edge over whatsoever we have been doing. One is if we talk of esophagus, it is the Barrett's esophagus with pathological low-grade dysplasia. The high-grade dysplasias, they can be easily picked up by endoscopy. Then it can assist endoscopists in identifying esophageal adenocarcinoma and squamous cell carcinoma and their invasion depth. Coming to another aspect is the prediction and effectiveness and prognosis of squamous cell carcinoma of the esophagus. If we talk of the stomach, artificial intelligence can predict Helicobacter pylori infection. It can also assist endoscopists in identifying atrophic gastritis, small intestinal metaplasia, early stomach cancer, and their invasion depth and prognosis. So these are important areas and conditions where artificial intelligence is certainly playing its role. So let us see what is the evidence. AI in Barrett's esophagus and early esophageal adenocarcinoma. Here we are comparing with best of the endoscopists trying to do his best to identify these conditions, and you can see that the sensitivity of AI is better as far as the picking up of the EAC is concerned, and it is at least not inferior as far as the Barrett's esophagus is concerned. If we talk of the esophageal squamous cell carcinoma picking up, multiple studies, don't go into the details, but just see the sensitivity and the specificity figures here. And you can see that they are hovering around 95% plus. So there, it is certainly better than the endoscopic evaluation of the esophageal squamous cell carcinoma. Another important area is HP. Even in day-to-day practice, we see that clinicians are not thinking about it. though it is very common in our type of population, that Helicobacter pylori, once you get it done, you will be surprised to see that it is present in significant proportion in patients, those who are coming to us with dyspeptic symptoms. And we are not treating them, we are treating them with just PPI, which is not enough. And here, AI is capable of detecting Helicobacter pylori infection to the tune of 88% plus. So these are very important areas where we are failing as far as today is concerned, and certainly we can pick up more of these patients with more accuracy about this. And now coming to systemic review and meta-analysis, I could find one on all sorts of AI done studies. And this area is something which is very close to our chairperson Ajoy Tiwari, who has done his MSc in systemic review and meta-analysis and will be presenting one in another conference. So picking up all sorts of studies and then filtering out depending upon what we really want to do is something which we do in the systemic review of the meta-analysis. And this is how we go. So we pick up all studies and then put our question to each thing and keep eliminating the studies and finally reach to a number which is fitting in perfectly to the question what we are putting to that particular analysis. And here, out of 2,600 studies, only 19 studies they were fitting into this, and the results were here. As opposed to best of the endoscopists, the diagnosis of Barrett's esophagus is equivalently placed as far as AI is concerned, and it is superior if suppose we are talking of picking up esophageal squamous cell carcinoma. So certainly AI is something which is there to play a significant role as far as GI GERD is concerned. Now I will not stop before practically picking up this one slide because so very important. We treat GERD but we forget about certain aspects. But as a good clinician, you should be focusing on to the first part, the lifestyle changes that makes a big difference in treating patients with GERD. Just elevating the head end of the person's bed, whenever the person is retiring, sleeping, the bed, even if it is 15% elevated, it helps these patients significantly. Reduces the time duration of PPI. If we talk of other things like ask the person not to eat complete food, whatever he is capable of eating, ask him to eat slightly lesser than what he wants to eat at that particular time. Smoking cessation is of course important, and then not lying immediately after having meal. So these are important part to really deal. Just not putting PPI, handing over the prescription to the patient, that is something which should not be done. This is a message which I like to communicate to you all youngsters, that try to play important part onto that lifestyle changes, that is very important. So we know that AI is attracting increasing attention in diagnostic imaging and complex medical data analysis. It has been observed that computer-aided diagnosis tools provides an interpretable universal methods of clinical, instrumental and endoscopic diagnosis of GI diseases. Thank you so much, but still I'll request my chairperson if they can give me a minute more, because I have completed my time. But this is important, a word about PPI. We are using it day in and day out. And if you see the literature, there are multiple places where PPI are put to question. Whether we talk of the increase in cardiac risk, maybe malignancies and other things. And therefore, a word of caution here from my side. Be careful about all these aspects. Maybe that the statement made in this Japi article that high quality studies have found that PPIs do not significantly increase the risk of any of these conditions except intestinal infections. But still, you have to be careful and using these long-term PPIs, and here is the best practice guidelines regarding use of PPI. Use it judiciously, use it cautiously, though it is required, but we have to be keeping in mind the side effects of PPI as well. Thank you so much for your patient listening.